Good afternoon, everyone. It's Roxana Moran. I'm here with my moderator and a fantastic panel of discussants. My moderator is Dr. Alexander Abazaid. Our discussants here, Marie-Claude Maurice, Chris Naber, Juan Iglesias, and we have a connected remotely with us, our discussant Rajneet Kapoor, and a chat master. And our chat master is very, very eager to get your questions. So please do go online and submit your questions for this session. This is Antonio Mangieri. So welcome to this symposium, What's Next in DES Technology? And you might imagine what could be next. And I think what we want to talk to you about is this innovative DES platforms combining DES with drug-coated balloons for the most complex cases and for the kinds of cases that we have coming into the lab these days. So we imagine that the objectives are to actually talk about how a drug-coated balloon and a DES can work together synergistically to treat patients, especially those complex patients with diabetes. We're going to show you those through some case presentations. We're going to talk about the efficiency of DES and drug-coated platforms with diabetes with a case demonstration. So there'll be a case in the box and even long-term follow-up. And to know this no polymer DES drug-coated balloon platform that can fill some of the gaps of our unmet needs. So I'll turn it to you now, Alex.
So thank you so much, Roxana. Good afternoon and a warm welcome to this very interactive symposium. It's sponsored by Concept Medical. One of my tasks this afternoon with you, as the vast majority of the PCR sessions, is to stimulate the interaction. So feel free to send the questions, and as much as we can, we're going to try to answer to all of them. So I think that without further ado, you can introduce the next speaker and the first speaker, which is myself, I guess.
Which is yourself, Alex, yes. Please, maybe Alexandre Abazaid, you can go to the podium and maybe talk to us about this lecture, which is Invisolution Technology Presentation. This is a pre-recorded case of imaging follow-up with abluminous DES and drug-coated balloon.
Maybe I could stay from there because there will be no live voice, the record.
That's fine.
Can you play it? I don't have to.
If you can play it, we can sit here, we'll watch it, and then we'll have a little discussion with the faculty.
The idea, Roxanne, is just to show the video straight, and then we can stop for discussion.
So strap your belts in and let's watch this beautiful show.
So before we start the case, I have to declare my conflicts, which are described in this slide. And again, with no further ado, almost live from INCOR in São Paulo. A very warm welcome from INCOR at the University of São Paulo. We are gathered here today to present a very interesting case of perhaps the longest follow-up of a patient enrolled in the ABILITY study. For that, I have a great contribution from Carlos Campos, who was originally trained at Erasmus, but now he is the chief of the Imaging Core Lab here at INCOR, and our senior fellow, Lucas Carlini, together with a fantastic team of nurses and tech, and Mara is our anesthesiologist today. So very briefly, I'm going to show you the study design, since this patient was randomized in the ABILITY in this very first slide. This trial was the largest randomized trial with 3,000 patients in diabetic population, randomized to abluminous versus Science, with a very aggressive endpoint at 1 year, not only non-inferiority against Science, but also designed to show superiority, since this is a novel technology. So this study was really designed to test the efficacy and safety of abluminous. And abluminous has a very unique design, combining a drug-coated balloon that releases sirolimus to the vessel wall with nanoparticles,
and a typical DES with very thin struts with unidirectional mode of transferring the drug to the vessel wall. In this next slide, you will also see some additional features of this device, which has a more concentration of drug at both edges to avoid any kind of edge restenosis. So this is a very interesting feature, particularly for diabetic population. We will have more intima hyperplasia in both proximal and distal sites, but also had this ultra-thin film that will protect the whole system when navigates to the coronary site, but also avoiding microparticle distal embolization. So several features that will make this device very competitive for the diabetic population. Being said that, I would like to invite Carlos to present the case and also the image modalities that we performed today.
So thank you, Alex. The case we are going to present today is a male, 60 years old. The patient came to the hospital with dyspnea despite optimal medical therapy after an acute event. So the patient had a previous MI, hypertension, diabetes. All patients enrolled in the Abiluminous trial, they must have diabetes, renal failure, and heart failure. Next, please. So the patient was really under optimal medical therapy. Next, please. So in the EKG, we see some Q wave in V1 and V2, but we see viability in the anterior wall. I will show you why I'm saying that. Next, please. In his laboratory test, I'd like to call your attention for mild renal disease. The creatinine clearance is 55, but also a severe heart failure with ejection fraction of 27%. Next. In the angiography, we see a severe lesion proximal in the RCA with some collateral to the LAD. You can go to the next, please. So the left coronary artery, we see some mild disease in the circ and a function total occlusion in the LAD. Next, please. So here it's more clear, the function total occlusion in the LAD. It's a long segment and diffuse disease distal in the LAD. So the syntax, the anatomical syntax score in these diabetic patients is 29.5. It's a long segment and a diffuse distal lesion. So Alex, what do you think of this case? This was 18 months ago.
Yeah, I think that, yes, we debated cardiac surgery for this patient, obviously diabetic, multivessel. But again, we were not super excited with this diffuse LAD lesion. I think that the distal bed is very questionable. So I think that if you can treat this patient percutaneously, and particularly with a novel technology, we might benefit. But again, this is a great debate, and it also exemplifies the kind of patients that we included in the ability study. And again, this is 1.5 years, so I'm very curious to see, Carlos, what we're going to find at 18 months after this procedure.
Perfect. So after the heart team discussion, the main reason was indeed the poor vessel quality in the distal LAD. So we decided to treat this patient with PCI, treating the LAD and the right coronary artery. So next. So the CTO recanalization of the LAD was not really complex, as we saw there was some microchannel. So we did antegrade wire escalation with a Feeder XT without big problems. So next, please. So here you can see a predilation with a 2.0 balloon. And then we can see the antegrade flow in the LAD. Next, please. So we implanted the 2.536 stent in the mid part of the LAD and a 3.033 stent in the proximal part, close to the LAD ostium. Next, please. So the post-dilation was with a trio balloon, non-compliant balloon in the mid part of the LAD and a 3.5 balloon in the proximal LAD. Next. So this is the final result 18 months ago after nitro. So you see the distal quality of the vessel in the LAD. So please keep rolling this angiography. So if you see the distal part of the LAD is small and diffuse disease, but we decided to keep implanting stent up to the mid LAD. Next. The PCI of the right coronary artery was not really complex, a proximal severe disease. Next. So pre-dilation with a balloon 2.5, implanting stent 3.040. Next. And then post-dilation with a 3.512. Next. But we saw a distal dissection. It was not major, but in our interpretation, there was a severe stenosis distal to the stent, so we decided to implant an additional stent in the distal edge of the first one. Next. Then we see a 2.516 stent implanted in this RCA. Next. This is the final result of the RCA 18 months ago. Next. So after this procedure, the patient had a major improvement in his symptoms, but also, I'd like to call your attention for the ejection fraction by MRI. So the patient had previously ejection fraction of 27%, and now the patient has a left ventricle ejection fraction of 53%.
So great recovery of the LV function. But again, multivessel disease with a total LAD. So I think that really tells us how complex these diabetic patients are. And again, now, Carlos, please share the late angiography and OCT that we have performed.
So first, the left coronary artery. There is no progression of the disease in the circ. So we see some mild disease in the first obtuse marginal, but there is no severe disease in the circ. The good surprise was the nice positive remodeling of the distal LAD. So they don't have significant hyperplasia by the angiography, but also we can appreciate increase in the diameter of the distal LAD after 18-month follow-up. So do you want me to show the OCT now? Or
show the LAD OCT, and then we come to the right.
Okay. So we look also these stents by OCT. So it's nice to see a good healing of the stent struts. Even in the region of stents overlap. So it was two long stents in this LAD, small LAD at that time. But even in this region of stents overlap, there is only a mild hyperplasia with a good stent healing in these two layers of previous stents. So this is the main findings of the OCT in this LAD.
So Carlos, I think this is a fantastic long-term result, after 18 months, highlighting the very good healing and good embedment of the struts. And just to call your attention, I think you're going to have much more data on OCT analysis between Azience and Abiluminous, because Antonio Colombo is finishing up a randomized study comparing these two stents with OCT.
So we also look to the RCA. So this is the angiography of the RCA. The stents look pretty good as well. So no hyperplasia by angiography. Also, there is no big progression of the disease. We see, however, some collateral to a small diagonal branch, but the RCA looks very good by angiography.
Let's see the OCT now, Carlos.
So like the LAD, we see also a good healing of the implanted stent in the RCA. So no significant hyperplasia in this RCA. Also in the region of overlapping stent, only mild hyperplasia with good healing of stent struts. So in summary, multivessel disease, diabetics, small vessels, function CTO in the LAD, and nice recovery of ventricular ejection fraction.
Thank you, Carlos. I think this was a great example, again, of a complex diabetic patient with very long-term follow-up. So we are very excited with this study, with this novel technology, and looking forward to the final results of this study. Thank you so much for your attention.
Okay.
Thank you, Alex.
The case is open for discussion.
Yeah, let's have a little bit of a discussion just quickly because we're a little bit short on time due to the difficulties, just like 4 minutes. So, Marie-Claude.
Oh, the case is incredible. Huh? Diabetic, too long stent on the LAD with overlap, the right coronary artery CTO. It's
18 months.
Yeah, 18 months. And you see this minimal hyperplasia at the overlap. That's
the edges look really clean.
Yeah.
Chris.
I couldn't agree more. This is a case which is complex because you would expect the restenosis because well, you can open this vessel, but what do you expect after 18 months? Usually starting diffuse disease and all this. And to see that this is clean is a very nice surprise. And I think we should even do more OCT after a long time because it would be very interesting. I think we could learn a lot about the mechanism of disease and about how we can prevent them. And this is what we saw here.
And we saw some remodeling downstream of the vessel,
that
better
impressed
flow.
me also.
Really
Do you think
impressive.
that there is some sirolimus nanoparticles that helped with that?
I mean, look, you know,
I think it was only underperfused.
It was probably an underperfused vessel. What?
Well, congratulations, Alex. It's a very nice case. And I mean, it highlights that it's not just about diabetic patients. It's about complex coronary artery disease with a long disease, CTO in this medial AD. So I think that you achieve a very good result. I think this platform allows these kind of approaches. And it's really nice to see the positive remodeling of the distal vessel. In diabetics, we have this very diffuse disease, and we tend sometimes to overestimate the length of our stents, and we tend to put longer and longer stents. And I think that your case shows very nicely that with time, these vessels grow up, and you don't need to treat extensively these vessels. And it's really important for this young patient. His LAD is still very important to get a distal target in case you need to have further surgery. So a very nice case. Congratulations.
I almost violated the protocol, Roxana, putting a magic touch distal. But then you would be very mad with me.
I would be very upset.
So I said, let's keep only the diabetes.
That's an important point. I mean, these cases in a very long diffuse disease, I mean, you can have this approach of combining a drug-eluting stent proximally, and you have the opportunity of using a magic touch distally, which combines the same features. And at the end, it's the same treatment using the same particles, the same sirolimus and composition to achieve a good result at the end in extensive disease like this.
Dr. Kapoor, any final comments before we go off our second case? We can't hear you, Dr. Kapoor. Are you muted?
Yeah, I can hear you.
Okay, good. Now we hear you.
Okay. So it was a very fabulous case. Just to tell you, in India, there is a lot of diabetic populations, and we get so many thin caliber arteries and small tapering vessels where such overlapping stents we do routinely as done in this case. So it is fabulous to have this technology where the healing is very good and the in-stent restenosis, intimal hyperplasia is very minimal. And especially the diabetic populations, such like arteries, they are very vulnerable for edge restenosis. So this technology where drug-coated balloon is also there at the ends, I think is further making it possible to obviate the chances of, to minimize the chances of edge restenosis in such cases.
Well, that's fantastic. We're making up some time, and I really want to get to our next case, so then we'll open it again with another discussion session where we can talk a little bit more. So if it's okay, I'd love to have our friend and colleague, Professor Reimers from Humanitas. He also has a recorded case with some follow-up. Bernard.
Now the sound is going to work, Bernard, because I was the guinea pig before.
But I have no videos with sound. So.
Oh, so good. Even better.
Okay. Follow-up is, I start with this, it's quite short. I think it's 17 days, but the patient is still alive.
That's good.
But
Well, tell us how
if
much
you
of
see
a
the
complex
case, that's
you did.
maybe already something like actually what we try. If you can open up my slides, I don't know what I have to do it.
So while Bernard is getting ready, just one quick question from the audience. If there was any baseline imaging in the case that we performed, no, ability did not mandate. Of course, it's according to operator discretion, but there was a lot of aggressive post-dilatation optimization, but this also highlights the fact that even without aggressive imaging, you have this kind of result.
But I would say in diabetic patients, specifically with complex disease, I always encourage imaging. I think we just learn more, we do better, we get the best optimal results, and these diabetic patients are extremely difficult.
With diffuse disease.
So I encourage, Chris, do you? Yes or no?
Well, yes.
The reimbursement issue as well.
I'm totally convinced that if you use imaging, you have to ask a specific question. This is the point. And if you have a specific question for the case, and it will change your therapy, then it's worth doing imaging. That's my only premises that I always have.
It sounds like Bernard had an imaging question. That's why he imaged the patient 17 days later. So Bernard, you're up.
Yes.
No, that was clinical follow-up. Okay, no, but I'm now working together with Antonio Colombo, and he said, no, Bernard, this is a case we have to show here. We have to show that we get the stent down, okay? And I think we still can learn something about it, a very complex case. I don't have any conflict. So it was a 79-year-old male, very tiny, small, a diabetic, of course, a smoker, creatinine 2.2, then it came also higher. He had the first cardiovascular event in 2020, but he self-discharged himself. Then in February this year, he came back to another hospital with heart failure, and the echo showed a 35 ejection fraction and hyperakinesia in the LAD territory and also in the RCA territory, and mitral regurgitation important. He did a SPECT, and there was a reversible anterior uptake defect and non-reversible. They did angiography. And as you can see here, quite ugly lesions, left main, LAD, circ, here also the marginal and the right diffusely diseased, but all vessels were open. Actually, due to extreme risk, the heart team in this hospital, they decided not to go ahead with revascularization and discharged him for rehabilitation. Then 3 months later, in May, so this month, he came back to our hospital, worsening dyspnea angina. He had peripheral edema and also bilateral pleural effusions. Creatinine was 3.5, BNP 4,700, and echo, as you can see, was stable, 35%. We had the heart team. And the decision was to try a revascularization with impeller support of the left system and not of the right, because there also SPECT showed no viability of the myocardium, inferior myocardium. May 3rd, so some days ago, single access, as we do always with the impeller. We did the echofluoro-guided puncture, so we both look with the echo, but also with fluoro for the bone landmarks. I think if you do one, you should do the second, at least in our hospital. Pre-closure with 2 proglides, maybe one is enough, but we want to be sure. And as you see later, quite calcified vessels in this patient. Positioning of the impeller sheet and the impeller, weaning up. Then we punctured the membrane here, as you can see, of the impeller sheet, which is in place, just with a normal needle and a short 7 French normal guiding catheter, introducer sheet, sorry. We introduced through the membrane, so we have 1 single access, and then we use the 7 French 3.5 EBU guiding CAS. He was on aspirin, we gave some heparin, and we used cangrelor because for the diffuse lesions, we like to do that. Afterwards, maybe we may discuss. Planned image modality, of course, IVUS, a lot of calcium, which were there, minimal contrast, 3.5 of creatinine, remember, so unfortunately we couldn't do OCT. And we, before that, also decided the 2 projections we wanted to work with. Here, impeller in place. A couple of projections, the AP caudal and the AP cranial, which nicely showed the lesions. And what you can see also here, the calcium, which definitely helped us. So far we had 8 cc of dye, also having decided before which projection we wanted to do, but which is easy here because you saw the calcium to see our coronaries. Okay, here I'm with Antonio Colombo. We said it's no use to try to IVUS immediately because too tight, so we didn't want to ruin our first IVUS catheter. We directly wired with a microcast, but it was quite easy, so it wasn't difficult. Used the 1.5 burr to prepare our lesion. After the 1.5 burr, you can see here, we definitely smoothed a little bit. You can see that there is calcium. If there is a limit 360, maybe it's also 420. Definitely it is already quite big, the lumen, because also the IVUS catheter went. But we decided to go also with a 1.75 because of this small diameter. So we had it set up, the Rota Pro. So we decided to do a further burr. We had a 7 French guiding catheter. After this, we used the balloon, what we normally do, the non-compliant high-pressure 24 atmosphere balloons, 3.0, in the entire lesion. And that was the IVUS result after 2 burrs plus the cracking with the NC balloons. And what you can see here, definitely at 2 o'clock, at 5, nice cracks of the calcium, and that actually in our algorithm that we use says that we have good lesion preparation and we can go ahead not needing for lithotripsy. This unfortunately is the only video which does not run, but after rotablation, the abluminous stent really went down very easily. We used 2 long stents, a 3.036 and a 3.528 LAD and LAD left main. So far, we didn't give contrast. We didn't have to because we can see everything here nicely with our calcium. Why abluminous? Because now this is a theme of today, new technology, maybe double safety to get the good results, because what we don't want is this patient to get him back to the cath lab because of his creatinine. We really want to do one-shot diabetic patient diffuse disease and try to make the best possible for him using a good preparation and using the best preparation and the best material that we have. We did kissing towards the circ. We did drug-eluting balloon on the circ, and then a left main pot. And that was the 3rd shot of contrast that we used that day. So we are at 12 cc of contrast. Here the angiographic. and IVUS result. We didn't want to touch the distal LAD because it would have been maybe also a too long stents. And this is the result on the circ, and this you may a little bit discuss it. There is a really huge dissection, but of course no flow limiting and quite nice lumen, as you can see also here in the IVUS run. So after kissing and POT, here's the left main with the 2 wires. Before, when it starts here, the run, you can see the circ. You can see the circ. Anyhow, it's a good lumen. And what we decided then is not to stent or not to do a double kissing stent. So we actually were quite pleased with this result and with this dissection, because the risk of occluding is, in our opinion, maybe less than the patient coming back for restenosis of the proximal circ. Aftermath, so with a couple of puffs, we did four projections, 20 cc of contrast. Impeller was easily weaned off, removed following the procedure. Also the sheet. Renal function was stable, so with 20 cc it's difficult to increase more the creatinine. He was in CCU for another 4 days, and he's still in hospital, but starting in the with mobilization and real rehab. So probably or on Friday or next Monday he'll be home. We still have to think about his mitral artery. What a little bit we can think, of course, is do we need additional lithotripsy? But we were quite happy with the outcome. And in our experience, rotablator makes your stents go down easier than lithotripsy, because lithotripsy you have 20 cracks. Here we had only 2, both sides, but which probably are enough to expand the stent. Maybe, I don't know whether you could expand better, but then afterwards to deliver the stent with all these craters or cracks of lithotripsy may be a little bit more difficult, but the Luminous worked very nicely. 2-stent strategy, okay, I think higher risk of TLF, and the patient is also an AF, so we had to get definitely a longer triple antiplatelet therapy. So he'll get 1 month triple, and then he goes back to double antiplatelet therapy with only a couple of stents. Cangrelor, we like very much. If the patient is not pre-treated, we give it for long lesions to rotablate. We observe less troponin, and also he didn't have any increase of troponin. I think image modality, of course, with this creatinine, the less of contrast you use, the better, and OCT is no meaning or has no value. Okay.
Move to the discussion. Sorry, I know we're going to talk about this a lot. Do you want to give us another
case?
Just quickly, because
just the last
really already
slide.
You're eating into our discussion.
Okay, excuse me. Just the very last slide, because what we normally do with our ability trial, here's a long lesion, not so tight. We delivered a couple of Luminous stents, and that's the work that we get from the Coreb Collab of Galway, of Patrick Beck, after doing our OCT. And here you can see, this is follow-up at 1 year, how good you can see the overlapping stent, how good you can see uncovered stent, so no intimal hyperplasia, but that were only 24 out of 5,800 plus struts. Malapposition also very low, so we post-dilated quite nicely. And these were the covered struts. And then at Galway, they also, which is 99%, they also measure the thickness of the neo-intimal hyperplasia of this covered struts. And as you can see here, they are, yes, covered, but with a very small thickness, medium of 96 micron. The stent is 73, so it's just doubles the thickness of the stent itself. So I think this is a really good long-term outcome with OCT imaging. That's how we get the patients back from our ability study. Sorry, thank you.
It's all right. Thank you so much, Bernard. Beautiful case. Unfortunately, we needed to have a few minutes for the discussion, and I'll just open this up. I mean, this was a really, really difficult case, right? I mean, I think shows the kinds of patients you're enrolling in. That was an ability patient, right?
No, we didn't. Well,
The second one is
it could have been an ability, but we didn't randomize them because we didn't feel we couldn't
you didn't
do
feel
OCT.
comfortable. There was no equipoise. You really wanted the
OCT. We don't want to get them back, and we still hope that we'll see him still alive in 1 year. This patient, of course.
but
There's
the 1 year
some more to
data-
do than the coronaries.
That second case you showed in the right coronary, I mean, excellent healing, really, really good. And really no intimal hyperplasia, very,
little, I think this is important. Some there is, but not nothing. So at least
quite
theoretically,
good.
that's what we hope to get out.
Quite good. Any comments, Chris? Short comment.
Short comment. I think what we see here is also that you can use a thin strut stents in these very heavily calcified patients. This is something convincing. These thin strut stents today are not to be compared with 15 years ago, where we had a lot of problems, but you see you can do it. But I still think using thin strut stents in these patients, debulking is favorable. So, just a comment.
Yeah, I mean, I think you showed us an incredible example of how difficult these diabetic patients are. Impella-guided, multivessel, severely calcified lesion, beautifully treated.
Good planning, algorithm, it went really smooth. So we really had fun.
Right,
I have to say there were no critical point.
Yes, just a small comment. We said since syntax that those patients with syntax score over 30, especially diabetic, should go to surgery, but many of them, surgery is not simply possible, and the surgeon doesn't want to take them.
And we want to have the best possible option. That patient would be denied surgery.
Yes.
There's no question about it.
It was.
Wow.
He was. Yes.
Amazing. We're going to move.
I'm sorry. Similar to the case in São Paulo, the distal bed was questionable.
Yeah.
So the surgeon.
Surgeons are.
Amazing.
They can do nothing.
Well, we're going to go to Juan Iglesias, and he's going to talk to us about nanoactive technology. Only 3 minutes, Juan.
Including the slides, I need 3 minutes to open them.
Have a little bit more time.
Let's
And
try.
then you're going to go right into your pre-recorded
Yeah,
case.
exactly.
So you can make up your time,
So
okay?
thank you, Roxana, for the introduction, and thank you to Concept Medical for the kind invitation. These are my conflicts of interest. So just in one slide, trying to convince you why we need innovative DES designs in 2022. You know from these individual patient data pool analysis, 19 RCTs, 25,000 patients, that even with newer generation drug-eluting stents, we still pay the price of approximately 2% annual rate of MACE and target lesion failure. And this is irrespective of the drug-eluting stent technology used, and this is mainly, as you can see here, without achieving a plateau. So we definitely need something new, and my task here will be to convince you that the Abloblins NP has unique drug-eluting stent technology features that require maybe some attention. First, we have an abluminal coating that facilitates monodirectional drug release. This reduces the systemic drug exposure and facilitates reendothelialization. Very importantly, as previously mentioned by previous speakers, we have this hybrid coating, not only on the stent, but as well on the balloon surface. And this is a combined DES and DCB design. And it's important here to mention that's the reason why we need to inflate these platforms up to, possibly according to IFU, to 45 seconds in order to ensure homogeneous drug delivery. The NP has a different feature from the DS Plus that you have seen. It's a polymer-free coating, and here the goal is to reduce the polymer-induced chronic inflammation, the fibrin deposition, to enhance vascular healing, and the optimal goal would be to shorten the APT duration. And there's this unique nanocarrier drug delivery, what's so-called nanoactive technology, and here one slide to summarize it. These are sirolimus microparticles which are encapsulated into a phospholipid drug carrier, and then this combination is sprayed on the stent surface, achieving, as I mentioned previously, the coating of both the stent and the balloon, as well as the two distal edges. So what are the advantages of this technology? We have a reduced drug dose, we have in-transit reduced drug loss as well, we have an increase in tissue drug bioavailability that improves in tissue diffusion and achieves an effective drug transfer to the deepest layer of the vessel wall to achieve early healing. So the ultimate ultimate goal of this technology is to reduce as much as possible chronic inflammation, to promote early vascular healing, and to allow short dab duration. So this platform has quite promising preclinical and experimental data, and we want now to push a little bit forward this technology to assess the stent in a dedicated investigator-initiated prospective multicenter open lab and randomized pilot study. And I'm happy here to share with you the design of the STARS DAB trial together with my co-PRs Michael Roffi and Marco Valgimili from Switzerland. We aim to include 350 all-comers patients with acute STEMI at 10 centers in Europe, primary PCI with the abluminous NP polymer-free stent, and these patients will be randomized 1-to-1 to two drug dual antiplatelet therapy regimens. The first one will be a short DAPT arm using only a single antiplatelet therapy with a P2Y12 inhibitor after dropping the aspirin after the primary PCI and before hospital discharge, and this regimen will be compared to the conventional DAPT arm up to 6 or 12 months according to the ESC guidelines. We'll have two co-primary endpoints for this pilot study. One would be safety, to demonstrate the non-inferiority with regards to major adverse cardiac events. And we have another co-primary endpoint in terms of efficacy, showing that this strategy reduces BARC 3 to 5 major bleeding at 12 months. And having said that, I would like to share with you one case we recorded a few days ago at our hospital, showing how this technology can be applied in a daily practice. And we'll share with you a case of a left main PCI. Hopefully sound will work. Mm-hmm. Well, no. Is there a way we can get the sound here or not?
Again, no sound, please.
This was checked, it was working before. Well, let's see if it's here. No. Present you today a very interesting case of a left main PCI with the use, one of the first cases across the world with the abluminous NP drug-eluting stent. So to start, I will ask Sophie to summarize the case of the patient we will treat today. Sophie?
This is a 71-year-old male patient with multiple risk factors. He is known for 3-vessel disease. He presented about 1 year ago with acute coronary syndrome and was treated with PCI to the RCA with 3 deaths. A few months later, he was treated with 1 death to LAD with a PCI for a CTO. Currently, he was admitted for a stable CCS3 angina. He's treated by DAPT, ACE inhibitor, beta blocker, as well as statin and ezetimibe. On admission, his troponins are slightly elevated. His renal function is normal. Echo shows EF 50 to 55%. He has anterior and septoapical hypokinesia. And on PET-CT, he has transferal necrosis in the territory of the left circumflex artery, and he has ischemia in the territory of the LAD. You can see here the coronary angiogram that was performed on admission a few days ago. On this slide, you can appreciate on the left-hand side occlusion of the left circumflex artery, as well as severe stenosis of the ostium of the LAD. On the right-hand side, you can appreciate the same stenosis in a cranial view. The patient declined surgery, so the plan for today is to perform left main PCI with a 7 French right distal radial access. The technique that will be used is provisional stenting of the left main to the LAD with a POT, kissing balloon left main, LAD, intermediate artery, and re-POT. As a reminder, the PET-CT showed necrosis of the L6 territory. The procedure will be guided by OCT, and PCI will be performed with abluminous NPDES, a novel generation polymer-free drug-eluting stent.
Just one word about the technique here. We have 7 French distal radial artery access with 7 French 3.75 EBU with 2 assigned cyan blue guide wires into the distal LAD into the intermediate artery. So let's start maybe, Marco, with the angiographic shots that we did today.
So also hello from my side. So you see here the cranial view, epicranial view. There is already a stent in the mid portion of the LAD. The stent was inflated up to 3.5 in the past, before the bifurcation with the second diagonal. And then you see here that there is the ostial LAD lesion, very tight, with some calcification. In the next view, this is an apicodal view. You can appreciate the severity of the ostial lesion of the LAD. So we performed a pre-dilatation with a very small balloon in order to be able to perform an OCT of the LAD.
And here we come proximally to the stent into the proximal LAD, which is quite diffusely diseased with a fibrotic and calcified lesion. This is a fibrocalcified plaque, as you can see here, from 4 to 6. So a calcium, a quite important calcium burden here. Here we come to the point of the proximal ostial LAD, which was already pre-dilated, and this is the the left main. So we did some measurements before starting, and so the proximal LAD just before the stent is around 3.5 millimeters, and proximally the left main is between 4.0 and 4.5. So maybe we can start pre-dilating here. So this is a 3.0 by 30 semi-compliant balloon, and we are in the previous implantly stent, so I think we can start here.
So we go up to 16 atmospheres.
Balloon opens pretty well down.
Yes.
And let's do some more pre-dilation proximally across the left main into the LAD, going from the ostium. Yeah. I think the balloon opens pretty nicely. Patrice, a 3.5 by 15 a non-compliant balloon, please. This is 18 atmospheres. The balloon opens quite nicely. I think most of the calcium is located at the ostium of the LAD and the proximal LAD, not so much in the left main. 20 atmospheres, and I think, Marco, that we have a very good expansion of the non-compliant balloon. So here we have the OCT run for in quite aggressive pre-dilation using a non-compliant balloon. You can see here this previous stent area, and we'll come into the proximal LAD. And you can see here very nice cracks.
Yes,
at 11,
quite effective.
At 5, so I think a quite good result in this fibrocalcific plaque, extensive cracks into all the segment of the proximal LAD. We come here to the ostium, some more cracks, some crack as well in the distal left main, and we are here into the left main. So I think that, I mean, from my perspective, we did a quite good job here in pre-dilating, and I think that we can go ahead with a stent that probably will go for a 3.5 stent, 32 millimeters length, that will cover the ostium of the left main until the previously implanted stent, and we will just work a little bit into the stent proximally into the left main to achieve a good apposition into the left main that will be assessed by OCT. This is one of the first cases performed worldwide with a stent, so we are very proud that this case is performed here in Geneva. So this is a newer generation drug-eluting stent, which is actually a polymer-free drug-eluting stent, which has a unique nanoactive technology. So the concept here is you have a platform which is a thin strut cobalt chromium platform with a strut thickness of 73 microns. And actually, so there are 3 different cell designs, 6 to 6, 8, and 10 cells, depending on the platforms. 3 platforms available up to 4 millimeters. And very uniquely, what this stent is different from the others is that the sirolimus, which is at a concentration of 1.12 micrograms per milliliter, is encapsulated into phospholipids, into submicron particles. So very small particles that are then sprayed on the stent and on the balloon to cover not only the stent surface, but also all the exposed parts of the balloon, as well as the extremities, both ends proximal and distal of the balloon. So the concept is here having a polymer-free drug-eluting stent coated with sirolimus, and the sirolimus is also coating the balloon. So you can see here the 2 markers. So the stent is 0.5 millimeters inside the markers, but the balloon, or let's say the coating, goes from proximal to the distal marker, so covering the edges of stents to prevent edge restenosis. And very nicely, this stent has also a very hybrid cell design with open cells in the middle of the stent, which allows for recrossing into bifurcation side branches, and a closed cell design at both extremities. So I think in this case would be quite nice to see how the stent behaves in this beforehand quite calcified lesion. and see how we can recross afterwards into the intermediate branch.
And so since it is 3.5 stent, we can go up to which size without disrupting the structure of the stent in terms of diameters?
We can go up to 4.5 millimeters, so it won't be a problem in this case. So now we are in position, and the issue here will be to land the stent just at the ostium of the left main. So for this view, I think that we should go the middle AD stent. So you see how the stent expands very nicely after preparing the artery.
14.
We have 14 atmospheres here and down.
Yeah.
So let's do now our port proximity, try to recross and treat the bifurcation now. So let's go for a 4O non-compliant balloon first, please. So this is a 4O by 15 balloon. Maybe we can start here.
Yes, this was where the lesion was initially.
Yes, exactly. So let's post-dilate the left main stent with a 4.5 non-compliant balloon, just to ensure that we are providing here a good pot to recross into the intermediate branch. So this is a 3.5 by 12 non-compliant balloon. Now, so it's time to recross the struts, hopefully the most distal strut into the intermediate artery to perform the kissing balloon. Yes, the balloon crosses very easily now, so we can open here. So this is a 1-0 sapphire balloon. All right, so now it's time to perform the kissing balloon with the two vessels. So we have a 4O incompliant balloon into the LAD, and we will use 275 by 12. 12 both.
Again, drop.
3, 2, 1, down. Great, I think we are close to the end now. We need to report into the left main, and just do a small image here to see what we did, and to ensure that we don't have a section at the ostium of the side branch. Looks beautiful. Okay, so now we need a 5O by 12, 5O by 12 non-compliant balloon just for the final pot, and maybe we can do a final imaging run just to ensure that we have the correct apposition into the left main. Yeah, I think we're nice here.
Yeah, it's fine.
Let's go here. Yeah. 12.
12.
And let's try to recannulate the stent by making use of the deflated balloon. So you have here the final OCT run, and as you can see here, so we are in the distal stent previously implanted, and we are coming to the area of overlap between the two stents. Somewhere here, and this is the proximal LAD. I think we have a quite nice result with a good deposition, a well-round shape of the entire segment. As you can see here, very nicely against the vessel wall. We're coming here to the bifurcation, which is nicely open, and this is the left main where we have a nice deposition as well with a round shape. So I think that we have a pretty nice result according to the TOCT, and now maybe Marco can just show us the last shots that we did.
Sure, this is the final areocaudal shot, and you see that the left main stent is perfectly apposed. We know it from the OCT already. It's coming to the ostium. The intermediate branch is really a big branch with no dissection of it. And so the stent struts open nicely, and then obviously we want to see last cranial view to see really that the LAD is fine. So here we can appreciate in a low cranial view that the ostium is covered of the left main and that everything is fine in the left main territory. So really a great result.
So with that, I would like to thank you, Marco. I would like to thank as well Sophie and the whole team, Patrice, Tiffany. We have as well Swad, Guy, who was previously here, and Gaetano was doing the technical part for this very nice case. Actually, hope you enjoy and see you soon in Paris. Bye-bye.
See you, bye.
Nice case.
Well, really amazing. I think these 3 cases exemplify the kinds of cases we're seeing in the cath lab, truly complex PCI in patients with diabetes. I think from this last case is really exemplary about imaging, the use of imaging. These operators, I want to congratulate you, the use of imaging in optimizing your results with the best possible stent at hand. Do you want to talk about, Chris, you said we have to have a reason why we image. I think in you have diabetes, we should be imaging. That's what I think. But let's open that up. We have good 6 minutes of good, healthy discussion. So maybe we start with you, Juan.
Well, I can more than agree with what you said, actually, regarding diabetic patients. We know that stent length is something that is oftenly performed in these kind of patients. We know that long stent beyond 40 millimeters of length have been associated with an increased risk of device failure. So, that definitely when you embark yourself in a long stented segment, imaging is a paramount importance just to ensure that you have a correct position and provide this patient the best outcomes, because we have to compare ourselves with the best, let's say, theoretical treatment would be surgery. And if you want these patients to be free of events, we then need to be sure that even if we are using the correct platform, that the job is correctly done at the end of the case. And for our case, that it's really for us mandatory to use imaging in left main PCI. That's been shown in several already studies, meta-analysis, and I think that this should be routine practice in using whatever, if affordable, kind of intracoronary imaging to perform these patient PCI cases.
Chris?
Yeah, no, I agree. But the point is, you need to understand the reason in order to do it correctly, because sometimes you say, I want to look for the size. What do you want to understand and what do you want to do? For example, in long lesions, I would like to understand also the landing zone, because very often in these patients, the landing zone is critical. You stand and you're just in the middle of the plaque, then you have to add another stand. Well, is this okay? No, probably not. And so I try to understand what I can improve. And
no, I think you're 100% correct. There are different reasons for pretty much everything in the sizing in a tapering vessel. But the left main, it's complicated, right? I just really think imaging is important. Marie-Claude?
Yes, I completely agree. And there is already 3 trials showing an advantage in mortality, up to mortality with imaging. So I agree that it's a must, especially because we are dealing with a tube that we put in 2 different sizes. And that we disturb to access the side branch. So let's say to be sure that what is done is properly done in a disease left main where which is a rare severe disease, mortality at 1 year even when well stented is above 2%. So having a perfect result is required. Really.
Yeah, I'm intrigued with your STEMI study that you're doing, 350 patients randomized to receive immediate P2Y12 inhibitor monotherapy. Is that correct? With prasugrel or ticagrelor. Is that right?
Yes, exactly. The rationale of the study comes mainly from 2 main questions that we should have as interventionists. First is whether we still need aspirin after our PCI cases, and second is whether we have the correct platform. If yes, we think we should avoid aspirin. If we have correct drug-eluting stent platforms and design that allow us to reduce the duration of the APT, even by withdrawing aspirin very early before hospital discharge. So Alex, maybe you know there's an ongoing study in Brazil, the NEO Mindset study. So this is a 3,400 ACS patient population, which is currently randomized with the same approach, but this is combining non-STEMI and STEMI patients. And we know as well from the studies, and Twilight is one of the nice illustrations that Twilight has only a non-STEMI patient, not STEMI patients. But when we see all the data available today with the P2Y12 monotherapy compared to conventional dual antiplatelet therapy, and we look at subgroup analysis, and we are currently performing a meta-analysis of this trial, we look actually and we see that the benefit is more likely to occur in ACS patients instead of CCS patients. So I think that really the need for a prolonged or even short DAPT can even be reduced to withdrawing the aspirin, and I think that this is a safe approach, and this is probably the way that we will treat our patients in the future, hopefully. And second is whether we have the correct platform, and we feel with this abluminous NP, we have several features here that allow us to make sure, at least be reassured by the fact that this stent can be safely used with an aspirin-free strategy. So our trial is a pilot study. We will see quite rapidly what happens.
Well, it could be ability too, I guess.
Yes, yeah, exactly.
And
Yeah,
we'll
but
see.
one cannot expect that utilization is began already at the end of hospitalization, one day two. No.
Yeah, we always want to see, right, polymer free for a more aggressive, short DAP duration. So this is going to be proving the concept. And I'm sure that these two ladies are going to be designing a 3,000-4,000 patient study to reduce DAP even more, if I know them. But I have a question from the audience here that we have to be interactive. And this is a very interesting question, by the way, Chris. They are asking if for very calcified lesion, we need double dose of sirolimus. This is interesting. I can start answering because we performed a study in Brazil a long time ago with Cypher called 3D, double dose diabetes. We doubled the dose of sirolimus in diabetic population, and I have to say there was absolutely no difference with a lot of imaging. But I think what is different and unique about this technology that we don't necessarily are doubling the dose. You're just distributing the dose more homogeneously, and we're going to have much more contact with the vessel wall, not only at the strut level, but also when you have a balloon, which is going to deliver drug through the gaps, right? So I think that this for diabetic, that's what makes it very attractive. But again, as far as I know, in a mechanistic study, doubling the dose of sirolimus is not going to have a huge effect in terms of inhibition of neurointima formation.
No, it's a good question. Dr. Kapoor, we didn't forget you. We know you're there. So maybe you just give us a few comments as well.
I think it's overall a wonderful discussion what you guys are doing there. So you have covered almost all the interesting facts and topics and issues related to complex PCIs, the dual antiplatelets. I'm also quite intrigued with the fact that these newer stents, like this abluminous, which actually provide us with a very fast healing. So 70% of the drug is gone in 1 month. So it provides a very good healing process. And in that, there are many subset of patients where we need to stop aspirin because of non-cardiac surgeries they have to undergo, or the high bleeding risk patients. So we can safely withdraw aspirin after 6 weeks or 8 weeks. So this is where the stents which are providing this fast healing are much more safer in these subset of patients which we are doing day in and day out in our practice.
Wonderful. Thank you so much. Well, now let's talk about ability. Can we put up my slides, please?
Yeah, I think you have to. Let me help you.
All right. Sounds good. No, we got it. It's there.
You did?
So I think it's really exciting. The times are exciting because diabetes is really tremendously important. I believe it's an Achilles heel of what's happening in PCI today. These are the patients that we should be sending for surgery, but we've seen many of them with complex disease are getting denied in surgery, and we want to do the best possible result on them. And so with this technology, maybe we're there. Important for you to note my disclosures specifically to my center, where I run multiple clinical trials, especially ability DIM. So this is a true epidemic. The prevalence of diabetes is increasing thanks to all of the great food we're all eating in the Western world. And if you can look at the CDC, more than 500 million patients will be having diabetes. This is something for us to pay attention to. And if we're these patients, their exit from this world is through cardiovascular disease and mortality from cardiovascular causes. And as a result, I think we absolutely have to get our arms around how to take care of these patients. And we saw data that Juan beautifully presented today with the long-term current generation DES. We're seeing an attrition rate of event-free survival because this is over time a 2% rate of MACE over a long period of time. And what you're seeing, here's the Swedish National Registry, you're seeing these patients, their causes of death, mostly myocardial infarction, cardiovascular disease causes, diabetes is a killer. It's increasing and it is contributing to the burden of cardiovascular disease and its morbidity and mortality. But there are some good news. On the medical management of these patients, there's been no better time than ever, especially with SGLT2 inhibitors. Now we have PCSK9 inhibitors. We really have to absolutely maximize medical management of these patients. There's no question in my mind that the best progress has been made through treating these patients with optimal medical management. But when you have severe angina, especially severe CAD in the left main, revascularization is a must. We know that, even in spite of best medical management of these patients. Coronary revascularization is something these patients will come to, and the question is what? And at the moment, with these patients who have high syntax score complex disease, most of them, we are supposed to be working with a heart team, that patient in the center of the heart team. What the EuroPCR is teaching us, everything we're doing is about the patient, what matters to them, and it's coronary revascularization. Many of these patients, especially the young diabetic patients, are asking us for PCI. They're denying surgery. Many of them don't have really good distal targets because of the diffuseness of their disease. So we've got to get better in our stent platform. And I think it's no question we are seeing that after coronary revascularization, there are issues with diabetes. Diffuse restenosis. We coined the whole diffuse proliferative restenosis, in-stent restenosis. That's the pattern of restenosis we're getting in these patients when these stents fail. We also see focal edge restenosis in diabetic patients often. And maybe because there's so much disease that the edges of the stents, no matter how hard you try, end up landing in some disease, and then you see this proliferation at the edges. That's why new technology is important for us to imagine. And I think it's very, very important to note about not just how the drug is distributed, but also the strut thickness, the polymer, and the type of the proliferative agents. These are the stent designs that are available, and we wanted to talk to you today about this abluminous DES, a cobalt chromium platform, sirolimus-eluting stent, polymer-free, incredibly interesting, 73 microns, extremely thin. You can see that 6 months degradation time of that biodegradable polymer with the abluminal fusion coating on the stent and the exposed parts of the balloon. And it's important because what's happening that's very, very different in abluminous technology is the crimping of the stent on the balloon and the drug coating after. So you're getting this very, very homogeneous distribution of drug delivery. Not so much about double dose, but rather about the drug delivery to the vessel wall on the abluminal surface. Really important. And I think what's important with our current technology listed here on the left and what we are seeing with this really exciting new technology is the pre-crimp coating, the abluminous coating, the fact that we now can address that issue of the edge restenosis, especially at the edges when the balloon of the current technology is not coated with any drug. And so you're getting a little bit of the best of both worlds. And of course, we believe that this could be great for diffuse disease, and also because of some of the reendothelialization, maybe even in AMI patients. But I'm most proud of this study, the partnership between Mount Sinai and CERC through an incredible executive committee, working closely with Marie-Claude Maurice and her team, and our team at Mount Sinai with our PIs, Sansei Saito, Alexandre Abezaid, and Antonio Colombo. We've designed the largest ever diabetes study. We didn't want to go small. We wanted to answer the question definitively. Can I have some water? Excuse me. So, 3,000 patients, 20 countries. Sorry. 100 sites. Every patient gets screened, they have diabetes, they're eligible for PCI, and they get included. We're randomizing them to the best-in-class stent, the Zion stent. Our primary endpoint is ischemia-driven TLR. We're powered for non-inferiority, but sequentially, we were also powered for superiority. It's really important to show that we could save TLR here. And target lesion failure, you see, we believe we will reduce TLR. Important secondary endpoints, as you could imagine. We're very excited about this study. Only 400 patients left to go. Even in the pandemic, 2,600 patients have been randomized. We're really, really excited. We believe we'll be finished by most likely July. So stay tuned. We'll be back in a year where we'll be presenting top-line results. Remember, diabetes is truly, truly a problematic issue for a lot of our patients. And we believe we have technology that absolutely could address this, and we're testing it in the largest ever study. Thank you so much for your attention.
Thank you, Rox. This was fantastic. I think that was a great overview and highlighted the problem that we live every day in our cath lab with the diabetic population. Of course, the expectation with the final results of ability is really increasing, right? I think that probably for PCR, let's do the calculation, Marie-Claude. Is it going to be not for PCR next year, a little bit later,
yeah,
right?
Yeah, a little bit later.
2023.
Yes.
For sure.
Yeah.
Good. So in 1 year, we'll be able to have access to these results. But before I give the word to the panel for final comments, I have a question, an interesting mechanistical question that I would like to address, and Juan is going to help me with that. If there is any limit to complete the process with this stent, particularly the polymer-free NP stent, as mentioned, with only 2 minutes of 1 or 2 minutes of inflation, of balloon inflation, based on polymer-free.
Well, what's important here is to realize that the concept is not just a drug-eluting stent concept. So we need to take into account that to achieve this homogeneous delivery of the drug, so we need a prolonged inflation as far as we can. In this case, it was, for example, in my patient, a left main PCI case. So unfortunately, we are not able to inflate for such a long time. But what's important here, you can do several inflations. So you can deflate the balloon, let's make the flow down the artery and then reinflate it. But it's really important to achieve as much delivery of the drug to the vessel wall, because this is the concept behind the technology.
And this is the beauty about nanoparticle, right? Because the nanoparticle is transferred to the vessel wall, and then the drug will be gradually, right, spread over the particle. So that's a concept that you don't need to keep the balloon inflated hours, right? It's just a few seconds, and that should do the job. Marie-Claude, any final comment on ability?
No, it's to finish with your comment. In ability, we have, as there is a film, polymer, we have to inflate for 45 seconds, and that's required for transfer of the drug and on the wall. No, let's say ability, as I could not say something better than Roxana said. That's incredible adventure that we are living with the company, the CROs, the PI. We are, of course, we are all crazy looking forward those results. Recruitment, as you said, was done in the COVID period. So showing how much the unmet need was there, because there was the COVID, the hospital were full of that, and despite that, the cardiologists continue to recruit, showing that they really believe that the need for the diabetic patient is there. And for me, that's the main message.
Perfect.
Yeah, I mean, it was amazing, the enrollment and the enthusiasm. And I think it just shows you that and we did this all-comer study in diabetics. I mean, it's very rare that, if you have diabetes, you're coming in for PCI, multivessel disease, you're in. I mean, it's pretty amazing, right?
Please, I have an interesting question for you, since you are a very experienced interventionalist, and this is something that we see every day in our cath lab. I see nowadays, particularly with my fellows, that we're going to deploy the stent or post-dilate the stent. It's 2 seconds, right? You deploy, you don't wait too much, you immediately deflate. Do you think that by using this technique, that very fast post-dilatation, we have enough time to transfer the pressure to really expand the stent? Because I think we should recommend that not only for the arm of abluminus, right, but also for the control arm, because we are doing a bad job with post-dilatation doing so fast. My feeling, there is no proof, right?
No, I think there are some data which people who looked at how fast the pressure translates into the balloon, and then and I think it was something like 20, 30 seconds that you need at least, but it will also depend on the balloon. So if you can do it longer, and you need to do at least 20, 30 seconds. I mean, 30 seconds is what I tend to do. I can understand that there are situations where you go very fast, because you have to. It's okay. But the routine should be do it longer. Otherwise, you will not apply the full pressure. Yeah, it will not be there.
But
and if you have a drug,
that.
If you have a drug, it's even worse.
So I think it's a good practice, perhaps, to train our brain to be a little bit more relaxed and wait a little bit, right? So I think the abdominal arm is doing that.
What do you think the ability is going to show, if you had to predict?
Well, it's a really exciting trial, and I'm even more excited because you know that the sugar trial results have been published last year. So I really feel that, in my mind, some devices have the technology to show benefits in subgroup of patients. We demonstrated it with ultra-thin strut technology in STEMI patients. It was the first superiority trial 2 years ago. And I really feel that this new technology is able to demonstrate differences. So I'm really excited, and hopefully it goes in the direction of sugar and showing that dedicated technology may provide superiority in this particular subset. I mean, we're looking back at all the data with new generation drug-eluting stents, either ultra-thin, either biodegradable, polymer-free. We did not show any difference between technologies, and I'm really sure that what Sugar showed 1 year could be shown with the ability trial with Abluminous, because this stent has clearly specificities that may apply most into diabetic patients.
So, Rox, I think we are less than 5 minutes to finish the session. It's your charge to give the final message and the take home.
No,
you have your voice back?
Yeah, I do. I'm totally fine. It was a little tickle in the throat. But first of all, just the audience being here, there's so much engagement, just having you all here. Thank you for coming to this symposium and recognizing diabetes as an important epidemic in the world. And we all have to face these patients. And not only do they have severe diffuse coronary disease, but they also have other issues, especially renal failure. And we saw exemplary work by Bernard Reimers and his team and colleagues in addressing some of the most complex, with Impella-guided PCI in a very, very complex patient with hardly any contrast to prevent AKI. Really important to think about these patients. They often have CKD. Combination of CKD and diabetes exposes patients to acute kidney injury. We have to, if we are going to take on PCI, not only do we have to take on the best possible device, we must get the absolute optimal result with intravascular imaging. We also must work hard to make sure that we're not damaging other organs, such as kidney injury, as well as stroke, obviously, in these patients. So really, really amazing work that was shown here through the different studies. You showed us follow-up late down the line, showing the durability of the results of this particular technology. Bernard showed us a very, very, I don't know how they thought, and the fact that they left this provisional stenting in the circ, really showing their confidence in using imaging in enhancing outcomes. And then your work with left main PCI using OCT pretty much in every step. And then choosing a stent platform that I think looks extremely promising. I don't know what the results will be. I do know that our data safety monitoring board is watching over the study, and they keep telling us continue enrolling. So that's a good thing, and we feel very excited about that. And I'm excited about the future for diabetic patients, because these patients often end up with multiple revascularization procedures, especially PCI. And to have something in our toolbox with our imaging, with the best possible way, but a device and a platform that could actually work in reducing target lesion failure could be absolutely amazing for our patients with diabetes. Don't forget, they will still need optimal medical management of their diabetes. These SGLT2 inhibitors not only take care of the hyperglycemia, but also heart failure now, and also reducing of major adverse cardiovascular events in combination with the best possible device. Probably now we can also have reduction of target lesion revascularization. I'm hoping for that, and we're waiting to see those results. And with partnership with Marie-Claude Maurice, I want to thank you all for being here, for engagement of thinking about this patient population. I want to thank our sponsors for thinking outside of the box with innovative technologies. I want to thank Dr. Kapoor coming in from far away on a time zone that's different than ours, I'm sure. Thank you so much for being here. And for all of you who were so engaged online with your questions, thank you, thank you, thank you. Bye.